Ophthalmic Symposium, topic that cataract surgeons don't encounter all that often, but when it happens, it's a real pain in the neck, and that's corneal wound burn, right? It's something that we don't see a lot, but I'm wondering if you can explain for...
Think our tip gets so hot that it can get really hot very quickly. But for the cornea, it actually goes, and you won't get much action at the tip, or you'll see some lens milk, okay? But concurrent, make a decision how to proceed from that.
The silicone sleeve that's fitting through the incision, but rather unknown until they're really coming forth. So what does it look like, if you can kind of give us a sense of...
Lenses, and you get in there, and it looks fine to hydrate the wound at the end of the case. In any case, the key is getting the nucleus out and wound. Sometimes it can be pretty straightforward depending on the amount of burn. Sometimes it can be quite a bit of a challenge.
Yeah. When you're closing, is that the type of thing where you can close with tenno nylon, for example, just like you would close any other regular wound, or is it a more complex process?
Yeah, it's generally a more complex process. Usually I'll use some type of mattress suture to try to get 2 vectors of closure. Oftentimes you need multiple sets of sutures placed. You're going to be inducing quite a bit of astigmatism because you get contracture. You want to think twice about perhaps putting in a multifocal lens or in that patient, or a toric lens, because at this point you've changed the equation on the corneal component of the astigmatism. Sometimes you can use cyanoacrylate glue. Multiple ways to approach it, but the key is at the end of the case you want that wound to be watertight if you can.
Sure, and I'm curious if you can speak to the astigmatic component that you mentioned. Is this a temporary astigmatism, or is it
irregular, or patient about taking out the stitches, or weeks, maybe even longer, and take them out sequentially? Because last thing you want is you take out the stitches slowly, but with the right contact lens or spectacle correction, they can get very good vision.
Sure. I'm wondering, Sam, if we can talk a little bit about treatment also. You mentioned that intraoperatively, the name of the game is to close that irregular opening as best you can with sutures or sealant or glue or some combination. But what about in the long run medically? Is there anything that you would consider using in terms of eye drops or other medical treatments in addition to what you would usually use for like postoperative care?
Yeah, I think I'd probably treat these more like you want to sort of let go through the process on their own. You want to embrace them and make sure that that you're there to help them through this. Luckily, it doesn't happen very often. Obviously, much less than a posterior capsule, and they almost end up with like a desmetaseal flap over it, so you have some structure in that area to prevent a wound leak and hypotony.
And how to prevent it or how to avoid it.